It's a pleasure to welcome you all to yet one another episode of CME India, brought to us by none other than Dr. N.K. Singh, sir. I would like to welcome all our speakers, Dr. Shenoy, our expert panels, Dr. Bijay Patni, Dr. Himalan Jha, Dr. Singh, sir, also. And I would like to take the privilege to welcome the person behind this initiative, Dr. N.K. Singh, sir. He is the Director, Diabetes and Heart Research Center, Dhanbad. Chairman, RSSDI Jharkhand State Chapter 2019 to 2023. He has been he has edited the Millennium Book of Medicine, ex-chairman of API Jharkhand, and edited monograph on COVID by API also, having numerous publications to his credit. It's an honor to have you here with us today, sir. I welcome you on behalf of Team USV.
Yeah, thank you, Arsil. So, welcome to you all, our respected speaker today and our moderators. I also welcome our core members. I think technical team, can you display the slides of Dr. Bijay Patni first? Dr. Bijay Patni, yeah. So I think the current designation is, you are well aware that HOD Diabetes Wellness Clinic at Kolkata. Lots of membership, as you are seeing here, and lots of research, and he is a really academic person, and lots of fellowship he has got. So Dr. Bijay Patni, welcome you all. And I think I now hand over to Dr. Bijay Patni to welcome our other moderators. Yeah, Dr. Patni.
Thank you, sir. Thank you, sir.
Yeah, can you show the Akash? Yeah.
Yeah, Dr. Akash is joined.
No, he has not joined, but he will be joining.
Yeah, Dr. Akash Singh is one of the core group member of the CME India USB group, and he is a senior consultant at Vadodara, and he is also a part of the director of EPGCD course in diabetes, and invited faculty at most of the conferences, national and regional, and has been contributed to various journals. And not only as a chapter in chapters, but also has written few of the textbook in diabetes. He's a reviewer of international journals in diabetes, and so welcome, Dr. Akash Singh.
Yeah, next you can display our moderators. Yeah, Dr. Himalaya will be joining. He is a special invitee today. He is the physician at Ranchi Internal Medicine. So can you show for the Dr. Abra Chaudhary? Yeah, Dr. Patni.
So Dr. Abra Chaudhary is from Calcutta, and he is present designation of consultant adult and pediatric rheumatologist, affiliated to ILS Dum Dum. His major achievements is Applar Fellow in Pediatric Rheumatology from UK, and numerous publication to his name, and area of interest is spondyloarthritis, lupus, and vasculitis. Welcome, Dr. Abra.
Hello, good evening.
Yeah, so one more Dr. He is the director and senior consultant at Ranchi, highly trained board certified rheumatologist, lots of membership, awards and recognition. So I welcome him, that is Devanis. And Dr. Abra Chaudhary, can you now introduce our today's speaker, Dr. Sinoy?
So today the speaker is Dr. Padmanabha Shenoy. He is a noted rheumatologist, and more so, he is one of our seniors from the same college. He is MBBS from the University of Kerala with lots of gold medals, MD Internal Medicine from JIPMA, DM Clinical Immunology and Rheumatology from SGPJ Lucknow. And he was the first Indian in 72 years to present a plenary session in the American College of Rheumatology conference. The ACR conference is one of our largest conference where most of the guidelines and most of the research is presented. And he is the recipient of DRA Young Investigator Award, Indo-UK Fellowship, JCR Fellowship, Clinical Immunology Society of USA Fellowship, Applar Young Investigator Award. And he is an avid researcher. He has research interest in immunogenicity of COVID vaccines, scleroderma, and palindromic rheumatism. And he has more than 50 publications in peer-reviewed journals, including the Lancet Rheumatology, Annals of Rheumatic Diseases, and NEJM. So welcome, Dr. Shenoy.
Thank you, Abra. At the outset, let me thank Dr. N.K. Singh and the entire CME India team for the kind invite, and Dr. Abro for his kind introduction. So Rheumatoid arthritis is a very common disease, as Dr. N.K. Singh was talking just before we started the meeting. So that it's a very common disease, and every physician comes across a rheumatoid arthritis most of the time, at least once a week. So in this case, the 30-year-old female, she presented to the physician with a arthralgia. So she does not have arthritis. She is telling, "Dard hai jodo mein." She has pain, but there is no swelling. Early morning stiffness is there around 20 minutes. When you palpate the joints, there is no clinical synovitis. Her so the first and foremost investigation when a patient comes like that to us, we do is ESR. ESR is around 30, and her IgM rheumatoid factor was done. IgM rheumatoid factor you can see here. Whenever you do an IgM rheumatoid factor, this is very, very important. Always do a quantitative is the standard. There are still labs we do which do rheumatoid factor by giving just positive and negative. That doesn't mean anything. You have to have the levels. And what you can see here, rheumatoid factor more than 20 has a sensitivity of 67 and specificity of 78. What does this simply means? It's very, very simple terms. Oversimplification means that if you take 100 people with rheumatoid arthritis, only 67 will be positive for rheumatoid factor. And if you take 100 people with rheumatoid factor positivity, only 78 will have rheumatoid arthritis. So it is neither sensitive nor specific for rheumatoid arthritis. And as the titer goes up, if the titer becomes 50, as you can see here, the specificity improves to 88. That is also not a great specificity, and sensitivity becomes 46. So what does it say is, its higher levels of rheumatoid factor is slightly sensitive, slightly more specific. And that's why sensitivity is low, because it is positive in a lot of diseases, starting from viral infection to parasitic infection to lupus to Sjogren's to infective endocarditis to tuberculosis to leprosy. So rheumatoid factor positive doesn't mean anything. It just says that if the patient has a clinical scenario, probably then we can diagnose rheumatoid arthritis. So it is neither sensitive nor specific for rheumatoid arthritis. But most important thing is, rheumatoid factor is a wonderful prognostic marker. It's a very good prognostic marker, because once this rheumatoid arthritis patient has rheumatoid factor positivity, it indicates that probably the patient is going to have a worse disease outcome, and the patient will progress and patient will develop erosions. So you have to treat the patient more aggressively. What about anti-CCP? It is also there in the market for last 15-20 years. The sensitivity is almost similar, 66%, but specificity is much better, more than 95%. So same sensitivity, but higher specificity when compared to rheumatoid factor. So how can autoantibody negativity rare in RA? A lot of physicians call me telling that the patient has patient has inflammatory arthritis, but rheumatoid factor anti-CCP is negative. So is it rheumatoid arthritis or not? This is a common doubt everyone has. The answer is 1/3 of the patients can have rheumatoid arthritis, can have seronegativity. So seronegativity is very, very common. Around 35 to 40% of rheumatoid arthritis patient will have rheumatoid factor and anti-CCP both negative. And as I told you, rheumatoid factor is very, very non-specific. It can be positive in a lot of other conditions. So coming to the index case 1, this lady had arthralgia. Her ESR, as you can see, is 35. And rheumatoid factor anti-CCP was done. And because it was female, ANA was also done, which was also negative. Hand X-ray was negative. Hand X-ray was completely normal, because it is a very early disease. What next? So we look at the ACR criteria. This is there for 10 years, 10, 15 years now. You can see here, she has arthralgia. She does not have any swollen joints. She does not have any tender joints, but just arthralgia. Her rheumatoid factor and anti-CCP is negative. So she has more very early arthritis. So her ESR and CRP are just elevated. That she gets only score of 1. That's all she gets. So this brings us to the other newer antibodies. What are the newer antibodies which are available? This is called there is a class of antibodies which are called anti-modified protein antibodies, or AMPs. Our first one was ACPA, which we commonly do, and it's a newer antibody which is going to come to market, which is called anti-carbonated P. For research labs, we are doing this, and anti-carbonated P, the sensitivity is very bad. Sensitivity is around 50%, but specificity is very, very high, 96%. So how does anti-carbonated P or anti-CAP add to us? What does it add? It is positive in 20% of seronegative. I told you around 30% to 30 to 35% of the patients of rheumatoid arthritis will be negative for RF and anti-CCP. But if you do anti-carbonated P, which is going to come to market soon, hopefully, it will be positive in 20% of seronegative cases. So you get slightly more. Yeah, adding these three, the sensitivity improves from 65 to around 75 to 80%. And what is more important is triple positivity. If somebody is RF positive, ACCP positive, and anti-carb positive, unless otherwise proved, is usually rheumatoid arthritis, unless proved otherwise. And very, very important, as we all do in clinics now, They already come to clinic. When somebody comes to you with arthralgia, we are not sure whether it's rheumatoid arthritis or not. You can do an ultrasound, which will show synovial hypertrophy, and you can also do the power Doppler, which is now most of the rheumatologists are doing in their bedside. You can see the power Doppler showing a lot of red signal. Red signal means a lot of vascularity. So synovium is very active. This is a study which was published around 10 years back. What it shows is they took 60 patients, 58 patients, less than 3 months duration of early arthralgia. And you can see here what happened. The ultrasound scored much better. You can see all the all the black lines are ultrasound synovitis. Ultrasound picks up more synovitis when compared to clinical counts. So especially in small joints and large joints also. So ultrasound is a very good tool when you are in a doubt, and you can look at Dopplers, power Doppler to look at for the increased vascularity too. So coming to the case 1, where we were not sure whether to treat or not, if she is anti-CARP is available, you can do that. Or more easily, what we do, you do an ultrasound, look at synovitis, look at power Doppler. If there is signal there, you understand it's going to be rheumatoid arthritis, and you start on hydroxychloroquine, methotrexate, or disease-modifying anti-rheumatoid drugs. When should you think other than RA? This is, I think, very, very important. This is whenever you have non-inflammatory pain. Non-inflammatory pain means you have the patient complains of joint arthritis, joint pain, but it's almost similar throughout the day. And if you palpate, there won't be any synovitis. This is a classical case of erosive osteoarthritis. If you look at a novice eyes, it may look like a rheumatoid arthritis, but there won't be any synovitis. There will be bony prominence. There will be Heberden's and Bouchard knots. So it won't be any, you won't have synovitis. And X-ray is diagnostic. And very, very important, I think I cannot overemphasize this. Psoriasis, we keep missing. How much ever you see in hidden areas has to be looked at. Any patient who has an inflammatory arthritis, even if RF-CCP positive, always look for psoriasis. Because psoriatic arthritis, a few % can have RF-CCP positivity. In seronegative patients, you have to doubly and triply be sure that it is not psoriasis. We keep missing this. Everybody keeps missing. Hidden areas we don't check in a BCOPD. Always, we also miss to check the nails. If there is nail changes or there is hidden areas are showing psoriasis, you should always, it's probably psoriatic arthritis. Never forget to check for psoriatic skin lesions. And when should you know? I think other than RA, whenever somebody has extra articular manifestations, like somebody has a butterfly rash, oral ulcers, there is a pleurisy going on, or somebody urine is showing proteinuria, urine is showing hematuria, or patient has thrombocytopenia or leukopenia or hair loss, then you should think of lupus. You know, in lupus, whenever somebody comes with a inflammatory arthritis, always never forget to look for extra articular symptoms. When should you think more than RA? I told you already. 1, fever. Fever is never a symptom of rheumatoid arthritis. Fever makes us think of lupus, stills, adult onset still disease, vasculitis, or viral arthritis, like chikungunya or other virus. Acute onset arthritis, less than 6 weeks. You have to keep your differentials wide open, because less than 6 weeks, lot of like viral arthritis can very closely mimic rheumatoid arthritis. Explosive onset arthritis, somebody just becomes bedridden in 2 weeks or 1 week, especially more than 60 years. It is paraneoplastic, is high on cards. So when this fever is there is an acute onset arthritis or explosive onset arthritis, always think something other than rheumatoid arthritis. And take clue from routines. Today, just I was staying around now. So I was telling my residents, one patient is there, they told it's rheumatoid arthritis, the reports are awaited. Patient is almost bedridden. The patient has a count of 4,000. And there's a lymphopenia. The total WBC lymphocyte count is, absolute lymphocyte count is only 400. So this gives a huge clue towards the diagnosis of a lupus. When a patient of has leukocytosis, count is more than 15,000, 16,000, probably you are looking at systemic onset JA or vasculitis. If it is a monoarthritis, probably it is septic arthritis. Patient has platelet count less than 75,000, 80,000. Lupus is high on cards, or hematological malignancy, especially in children. We have seen a lot of ALLs presenting to us with severe joint pains. Patient who has urine abnormalities in the form of probably has lupus or vasculitis. Other one is raised OTPT. I cannot overemphasize this. Last week also I saw one patient has inflammatory arthritis. OTPT is around 200, 300. Liver biopsy was done. Liver biopsy is normal. Ultimately, the source of OTPT was muscle, and the muscle CPK was around 3,000. And patient was on statin. So that was the reason for that patient's CPK getting elevated. So we have to be very, very, whenever OTPT is elevated above a limit and GGT is normal, always never forget to look at CPK. This we keep forgetting. And autoimmune hepatitis is another differential. So now I will show you 2 to 3 cases. So I have told you how to suspect rheumatoid arthritis, how to diagnose rheumatoid arthritis. Now let us see some close mimics. 24-year-old male who is symptomatic for 9 years with deforming polyarthritis associated with fever, high-grade fever. And he has nodular lesions over the feet and the hands. And also there is swelling in the bilateral feet. There is swelling in the feet and also there is deforming arthritis. And you look at his ESR. ESR is 110. His RF is negative, but he has uric acid is 10.6 and severe albuminuria. You can see 4 plus albumin and 24 urine protein of 8.6 gram, almost nephrotic range proteinuria. And this is a entire digits are damaged. You can see from this thing. If you look at his first, you will think he has rheumatoid arthritis. But what was odd? He had fever. Also, he had nephrotic range proteinuria, and he had lot of erosions in the hand. And because he had nephrotic range proteinuria, a kidney biopsy was done, and you can see here there was a crystal sitting here. Lot of crystals in the kidney biopsy. The biopsy showed lot of crystals in the biopsy. What is it? These are uric acid crystals. And why he had? Because, and you can see the glomerulus here and with a eosinophilic material here. What is this eosinophilic material? This was nothing but apple. You can see the apple green birefringence. It was serum amyloid. Amyloid A amyloid getting deposited in the kidney because of the severe polyarticular gout. So diagnosis was very simple. He had secondary amyloid, secondary to chronic gout. Treatment was, he was treated with colchicine and febuxostat. He improved, his fever subsided and proteinuria decreased. But he was being managed as rheumatoid arthritis. Case 3 is a 40-year-old female, inflammatory polyarthritis for 3 years, paresthesias of the hands. So there is severe inflammatory polyarthritis. There is no doubt here. You can see here, severe inflammatory polyarthritis. Her ESR is 120. Rheumatoid factor was positive. She was being managed by someone for as rheumatoid arthritis. Has shown hydroxychloroquine and methotrexate for rheumatoid arthritis. And you can see here already her one joint was replaced because of rheumatoid arthritis probably. There was hip was damaged and hip was this thing. She had a issue in left hip. The history was that not very clear, but it was replaced. You can see here her shoulder is also showing lot of synovitis here. So I will show you something probably. Look, what was the odd point here? Look at her shoulders. Shoulders are very, very prominent. This was a very odd point. It is like a feminine shoulders, very prominent shoulders. You can see here lot, and by now probably astute physicians will guess what this is. Her tongue is showing macroglossia and she has shoulder pad sign. And you can see the MRI. MRI shows lot of deposits around the shoulder. It's not synovitis, lot of deposit disease. And we aspirated, aspiration showed nothing but amyloid. You can see the apple green birefringence is again here. So she had myeloma with AL amyloid. Her AL amyloidosis was very high. Serum light chain was very, very high. 1000 or something. So she was diagnosed as myeloma with AL amyloid following a bone marrow. So this lady also had rheumatoid arthritis-like picture, but had some other manifestation which led to the diagnosis, and it was the clinical suspicion which led. Case 4 is a 57-year-old gentleman, diabetic for 5 years, inflammatory arthritis again, RF strong positive, ESR 70, and he had paresthesia of the lower limb lasting for 2 to 3 years. You can see here what happened. You can see here there is madarosis here, and also his face is very typical of something. And I am sure the northern part of India sees a lot of cases than southern part of Kerala. We don't see so many cases of this. And his radial and ulnar nerves were thickened. No marks for guessing what he has. He had skin biopsy was done, which showed granulomatous inflammation with Hansen's, and lepra reactions are very close mimic of rheumatoid arthritis. So till now, 4 cases, 3 cases, why I showed was the most important thing is to make the correct diagnosis. Rheumatoid arthritis can have a lot of mimickers, and it's very easy to misdiagnose rheumatoid arthritis in a case of leprosy or myeloma or sometimes infective endocarditis, etc., etc. You have to be very, very clever. Subacute infective endocarditis can have inflammatory arthritis. I have 2 or 3 patients who just presented with arthritis and very low-grade fever, ultimately had infective endocarditis. So case 5 is now I will come back to rheumatoid arthritis. So extremely important to make a very correct diagnosis at the outset and be very sure that rheumatoid arthritis. Still, we have to keep our eyes open for other manifestations if they appear. So this case 5 is I was seeing this lady for almost 7 to 8 years. She came to me in 2014. 55-year-old female, wife of a doctor. So she was seropositive rheumatoid arthritis. Diagnosis was very clear: florid arthritis, florid synovitis. Rheumatoid factor was strongly positive. Anti-CCP was more than 200. She is unable to walk. She came in a wheelchair. Tender joint count was 16. Swollen joint count was 12. ESR was very high. And you can see the DAS28, 7.1. So how I manage this patient? I will take you the story of what are the options available. So when the first rheumatoid arthritis patient comes to us for the first time, after confirming the diagnosis, what do they expect? What the current day expectation of rheumatoid arthritis patients? In 1980s, it was non-treatable. There was few drugs. Senior clinicians here will know who did practice in 1980s. There were not much drugs. Probably there was NSAIDs, steroids, and gold. They have heavy adverse effects, and all the rheumatoid arthritis patients used to suffer from severe pain, 75% work loss in 3 to 4 years, and majority required joint replacement surgeries. Now, and remission was extremely rare. What now? Remission is, people have to work. Remission is a norm. Normal working happens in 99% of the patients. Cost has significantly come down, and we need to prevent surgeries. And now people are talking about cure, or it means drug-free remission. Can we achieve that? That is the futuristic goal. So expectations have dramatically changed from a patient side and what is achievable. How can we use disease-modifying anti-rheumatoid drugs to meet the expectation of patients? Patients don't want, so they want to work, they want to attain remission, they want to have a normal life. So let us start with conventional synthetic. So what are the DMRs we have? Group of, first is conventional synthetic DMR, methotrexate, chloroquine, sulfasalazine, and leflunomide. Biological DMRs are there: anti-TNF, anti-IL-6, anti-B cells or rituximab, anti-CTLA or abatacept. And then there are targeted synthetic DMR like jacnib, tofacitinib, or baricitinib, or upadacitinib. So disease-modifying anti-rheumatoid drugs, I want to spend, I am sure all of you must have used extensively these drugs, but I just want to emphasize on 2 or 3 points. Hydroxychloroquine doses around 200 to 400 milligrams. Always remember, HCQ is a very, very mild drug. It takes 3 to 6 months to start acting, minimum 2 to 3 months to start acting. So there is a lag period. And this, so I have seen people start hydroxychloroquine within 2 weeks, change to methotrexate, change to leflunomide. All these drugs take time to act. They don't as fast like what you would like them to act. And how do you monitor it? You have to do basically the issue with hydroxychloroquine is retinal toxicity. It's very, very rare. Again, after 5 years, the chance is around 1 to 2%. So if you annually check the patient's eye, it's extremely rare. And skin pigmentation is another major issue, especially somebody is white. Tanning is a huge issue after 2 to 3 years. Hydroxychloroquine is a very safe drug, but very mild. What about sulfasalazine? Sulfasalazine is another DMR, again very safe. The only issue is hypersensitivity. It's if you had a sulfa allergy, you had it. I'm sure with Septran and other drugs, all of you must have faced sometime or the other in the life. And oligospermia in males is another issue. And dose is 3 grams per day. The lag period is slightly lower, around 2 months. Still, it takes 2 months to act. Methotrexate, always remember, methotrexate may not act when you give we underdose it. 5 milligram or 10 milligram will not work. You have to give stiff doses, 20 to 25 milligram in most of the patients. And the major issue is we have to clearly monitor these patients. Liver function test has to be done because it is known to cause hepatic fibrosis. It is known to cause bone marrow suppression. And always check regularly, at least 2 to 3 months. Even if the patient is in remission, 2 to 3 months, call back the patient, see how the patient is not having any adverse events. It has to be very clearly monitored. But HCQ and sulfasalazine are relatively safe when compared to methotrexate. But methotrexate is the best anchor DMR we have. There is no drug which is comparable to methotrexate. Even tofacitinib is slightly superior, that's all. But methotrexate at very low cost achieves very good outcome, but you need to closely monitor. Leflunomide is another very good drug, almost similar to methotrexate, and again almost similar side effects, except that it can cause diarrhea and asthenia, weight loss, and sometimes it can cause hypertension. From a physician point of view, if a rheumatoid arthritis patient come to you, he's on leflunomide, hypertension is not getting controlled. One of the major reasons is leflunomide. And second thing is, it can cause peripheral neuropathy. Again, mild peripheral neuropathy, which is gradually progressive. Probably people attribute to diabetes, but leflunomide also can cause. So this is disease-modifying drugs. Now people think newer drugs have come. I have seen a lot of physicians writing tofacitinib upfront. Let us see how effective these DMRs are. So is there any HbA1c in RA? My first point is, if any one of you is treating rheumatoid arthritis, please measure the disease activity. If you're not measuring RBS or HbA1c or not checking blood pressure, how can you treat rheumatoid arthritis or how can you treat diabetes or hypertension? Similarly, without looking at the disease activity, never treat rheumatoid arthritis. So there are 3 or 4 indices. One is DAS28. DAS28 is a formula. It's easily available online. And point I want to make is based on the scores, if it is less than 2.6, it's remission, and more than 5.1 is high disease activity. Based on disease activity, you can give scores. And there is something called a simplified disease activity or something. Last one is clinical disease activity. Just count the tender joint count, swollen joint count, how many joints are tender, how many joints are slender, what is the patient global assessment, and what is the physician global assessment out of 10. And then you add up everything, just add, not ESR is not required, CRP is not required, just add everything together, you will get a score. Any of the score is easy enough, but you have to count the joints, you have to do this, put this effort so that you quantify the disease. And if the patient is in remission, high disease, very clearly it has been shown, if a physician does this disease activity measurements, the patient's long-term outcome is extremely good. But we should never treat based on gut feelings. ठीक है, पहले मेरे को बहुत दर्द था, अब कम हो गया, और now I am better. That kind of feeling doesn't work, because sometimes what will happen, you will have to control 90% of the disease, 10% disease will remain in 1 or 2 joints, and that joints will get damaged, and patient will be very unhappy at the end of 5 or 6 years. So now I am going to efficacy of these drugs. What is the benchmark? Benchmark is anti-TNF probably, because these drugs are very, very effective. If you see ACR 20, 50 and 70, you can just remember just ulta 70, 50, 30. ACR 20 means ACR 20 response, ACR 50 means 50% response, ACR 70 means 70% response. So 70, 50, 30 will be the easiest thing to remember. ACR 20, if a drug can achieve 70%, it is a very good drug. And ACR and remission happens around 20 to 30% of patients, whichever drug you give. So this is a very early trial. Why I'm showing this is just to emphasize how effective the routine drugs we are using currently. And let us not forget all these gold. Intensive treatment with methotrexate in early arthritis is called a camera trial, which was published or called close to 20 years back. Very simple study. One is intensive treatment trial, monthly visit, hike methotrexate to 30 milligram in 4 months, and add cyclosporin if the patient does not improve. Conventional group, 3 monthly visit. So rheumatologist can adjust whenever, whatever he feels like, but the other one was structured. Every month you have to increase, 4 months, it has to be 30 milligram. And they took very early RA, within 1 year, around 300 patients were randomized. You can see here the difference. In the intensive group, 40% achieved remission at the end of 1 year, and around 50% achieved remission at 2 years. So as you can see here, remission, what we expect is something around 20%, but we overtook this. This is just methotrexate monotherapy. In early arthritis, 50% of them achieve remission. Remission means TJC 0, almost 0. So it is very good. Even methotrexate monotherapy is very effective. This is another trial which is called FINRACO trial, where took again early rheumatoid arthritis within less than 2 years, and they were all steroid DMR naive. And you can see here, they compared combination therapy versus monotherapy. Sorry. Combination therapy versus single therapy. They gave multiple DMRs versus single DMR. As you can see here in all these figures, this is combination therapy, this is monotherapy. You can see here all the combination therapy arms, be it ACR 20, ACR 50 or remission, all of them are much better. Just compare between these two. Here. All, especially remission is much higher in combination arm when compared to monotherapy arm. At the end of 2 years also, almost similar. Combination therapy did much better. And look at the remission rates, around 40 to 50%. So what it says is, the combination is superior to monotherapy. Initially, we told monotherapy is effective, but when we give monotherapy versus combination, like what do you mean by combination? Giving 2 DMRs, methotrexate, sulfasalazine, hydroxychloroquine, or 1 or 2 DMRs together is definitely superior. And adverse events in the combination versus monotherapy is almost similar. And this is again the 11-year data. The same group, it was continued, and they were given after 2 years. Rheumatologist was free to give whatever they want to give. And you can see here, after 2 years to 11 years, they had a very good follow-up. Almost 11-year follow-up they had, because Finland and all, the long-term follow-up is extremely good. And look at the disease activity. The combination therapy arm, the remission rate was around 70% versus single therapy arm around 40%. As I told you, after 2 years, both of the group got standard of care. They got infliximab, they got rituximab, some of them got azathioprine, whatever they want, the rheumatologist could give. But what does it teach us? 63% of the patients were in remission in the combination arm versus around 40-45% in the single drug arm. So it didn't change after 2 to 11 years. Whatever therapy they got after 2 years did not matter. It mattered less. What mattered was how they were treated during the initial 2 years. So initial 2 years disease control is extremely important to control the disease activity for long. And initial control is most important. And from a non-treatable disease, this study 11-year follow-up very clearly showed that from non-treatable disease, it has become very much treatable. And look at the functional, they have shown 11-year function also. And 50% of the patients had a totally normal function at the end of 11 years. And also, and another 20-30% had very, very mild disability. Very mild disability means you can't jump around, you can play cricket, that kind of disability. So majority, 70-80% of the patients have almost normal physical function at the end of 11 years. So 75% work loss initially to 75% near normal function. This is another study which is called TICORA trial, which is, they did nothing. One group, they took early rheumatoid arthritis, what we see like less than 5 years, intensive treatment versus routine management. Intensive means, routine means 3 monthly visit. And if the physician wants, you can give combination therapy, or the physician doesn't want, you can give monotherapy at the discretion of treating rheumatologist. And you can see intensive group was a fixed chart. I don't want to go to detail because of lack of time. Intensive group was given, if the disease is not controlled, you have to up titrate 1. So keep on adding drugs at the end of 2 to 3 months. You can see here, look at the ACR 20, 50, 70 response. ACR 70 response is 71%. With anti-TNF, we achieved 35%. Extremely good results. This TICORA trial showed us that it is not the drugs which matter, it is the strategy which is important. So most of the time, people will come and say, I have taken methotrexate, I have taken sulfasalazine, I am not responding. Patient is not responding. Probably it was not given an appropriate dose and appropriate combination. So it is not the drug which is important, it is the strategy which is important. And strategy is intensive management and treat to target. The problem is people don't measure disease activity. Even if the people measure disease activity, they don't strive for remission. What is remission? Remission is -28 less than 2.6. And how can we achieve that? Aggressive treatment. Most of the time, even if starting with a single DMR is fine, but you need to up titrate. You need to add drugs. And extremely important, tight control of disease with frequent follow-ups. Initially, when the disease is not controlled, at least follow up 1 to 2 monthly and control the disease activity as early as possible, because that is the benefit you are going to reap in the future. So coming to the first case, she had high disease activity. As I told you, the patient was started on methotrexate, hydroxychloroquine, and low-dose glucocorticoids, injected the knees. She did not respond. Again, at the 3 months, he had DAS28 of 6.4, ESR is 80. So basically, what is this? Combo DMR failure. She has not responded at all. Even she has not achieved ACR 20 response. So she's a combo DMR failure. So you have given first-line drugs. First-line drugs are effective in 70 to 80% to an extent, and very good, very well effective in 60% achieve remission. So some of them don't respond. So what next? Then we have biologics. Biologics are also there in the market for the last 10 to 15 years. These are the three or four major biologics what we use. One is anti-TNF. You must have heard of etanercept, adalimumab, and tocilizumab is interleukin-6 blockade. It was widely used during COVID. Rituximab, all of you must have definitely used or seen. Rituximab is anti-CD20 monoclonal antibody, and abatacept is currently not available in our country. So I'm not just going to details of that. So anti-TNF, tocilizumab, and rituximab. Rituximab is a drug I often use. Rituximab is a drug which is given as IV infusion, very effective drug. And as you can see here, in patients who are not responding to conventional synthetic DMRs, rituximab is effective in another 50 to 60% of them. And anti-TNF also almost similar result, ACR 20 of around 50%. And tocilizumab is, these are various studies with tocilizumab. Tocilizumab is anti-interleukin-6 blockade. The problem with tocilizumab is tocilizumab has to be given on a monthly basis or a 2-weekly basis based on the what IV or subcutaneous you choose. It is a costly therapy. The cost is around 17 to 18,000 per month. Anti-TNF is also similarly costly, 17 to 18,000 per 10 to 15,000 per month. And rituximab is slightly cheaper. For 6 months to 8 months, it will cost 15,000 rupees. So per month, the cost is around 1,500 rupees or 2,000 rupees. So out of these biologics, rituximab is the most cost effective, and it has to be given as an intravenous infusion. So she failed on combo DMRs. I started her, and she had a high disease activity. So I started on anti-TNF. etanercept was given twice a week for in 2015. So 1 year later, she was on anti-TNF, not much response in 3 months. So she had again ESR of 70, slight decrease in disease activity because, and you can see here, 12 became 10, 10 became 8, very, very minor response. So she has not responded at all to anti-TNF. So when anti-TNF also fails, what do? You give rituximab. If one biological fails, you give other biological. Or anti-TNF fails, you can give IL-6 blockade, tocilizumab, or you can give rituximab. And you can see rituximab here, if you give in anti-TNF failures, the response rate is around 50 to 60%. So reasonably good number of patients respond to another biological. So she went to CMC Vellore for second opinion. And as rightly at that time, 2015, she was initiated on rituximab. 4 months back, she had no response. X-ray knee worsened. TKR was done in 2016. Within 2 years, she had to replace her knees. Such was such aggressive disease. So in November 2006, suddenly I'm seeing her back, wheelchair bound, despite total knee replacement. Her hips were very painful. She was rolled into my room. Again, I was depressed because she had picked up, she was very early diagnosed. Despite that, we couldn't control her disease activity. She had failed on disease-modifying anti-rheumatoid conventional drugs. She had failed on anti-TNF. She had failed on anti-B cell therapy too. Now what? So that is the time, 2017-18 was the time when JAK-STAT pathway inhibitors were launched or being available in the market. JAK-STAT pathway inhibitors inhibit JAK pathway, which is a very important downstream signaling pathway for most of the cytokines. So I don't want to go into details of pathogenesis or mechanism of action, but JAK inhibitors, there are a lot of JAK inhibitors which are available now. Most commonly available one is tofacitinib, and upadacitinib is also launched now, and baricitinib also will be is being launched very in recent future in our country. How do they differ? Very simple. Upadacitinib is selective JAK1 inhibitor, supposed to have some superiority over tofacitinib, but not much in terms of clinical trials. Results are almost similar. Tofacitinib is non-specific. It is a JAK1 and JAK3 inhibitor more than JAK2, but it also has a JAK2 inhibition also. Baricitinib, again, very, very widely used during COVID, is a JAK1 and JAK2 inhibitor. Filgotinib and upadacitinib both are selective JAK1 inhibitor. All these drugs are approved for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, and polyarticular JA, alopecia areata, etc., etc. And some of them are approved for even ankylosing spondylitis. So the first 4 ones are the one we commonly use in currently in clinical practice. So if you look at the efficacy trials, these are across spectrum. Just look at the bottom. Methotrexate naive, methotrexate non-responders, combination disease modifying rheumatoid failures, TNF failures, across spectrum, tofacitinib is extremely effective. You can look at the response rate. Around 60 to 70% achieve ACR 20. These are the name of the trials, very difficult to remember. No need to remember. It is across spectrum. Just remember, tofacitinib is across spectrum is effective. And even it is comparable to adalimumab. You can see here in oral standard trial versus anti-TNF, in methotrexate indicated responders, tofacitinib was numerically superior to adalimumab, but clinically not statistically significant. So it is superior. In baricitinib, RA build trial, RA begin, RA beam, and RA beacon, almost similar results, almost same population. In again, it is also effective across spectrum from DMARD failure to methotrexate failures to anti-TNF failures. It is equally effective, but usually one JAK inhibitor fails, unlikely that other JAK inhibitor will work. But what is the issue? The problem is in 2020-21, tofacitinib was launched in our 2019, I think. Now it is 6 years. Tofacitinib was launched in our country as a generic version was launched. And there is a huge misuse of tofacitinib. Pharma companies promote it as if it's a panacea for rheumatoid arthritis, all rheumatic diseases. I keep seeing even osteoarthritis patient getting tofacitinib by orthopedicians. So it has to be hugely discouraged. Why? One thing, tofacitinib has risk of tuberculosis. This is a major trial which was published. Initial trial of tofacitinib. It was in India was one of the sites which recruited. If you can see here, they excluded patients with latent TB. They did MAN2, they did quantiferon TB gold, and they excluded patients of latent TB. Still, TB rates were 1.21 per 100 patient years, while in West it is 0.1. So almost 8 to 10 times, risk is around 6 to 8 times when compared to the West. And over years, the risk of tuberculosis stays high. And what is serious infections like pneumonia or urinary tract infection, which require a hospital admission, you can see another 3 to 4% across time develop serious infection. In other biologics, during the initial period, when the patient has high disease activity, that is the time they get infection. But in tofacitinib, it remains high throughout. And look, it is almost similar to other biologicals. You can see here the odds ratio of developing the serious infection is almost similar, 3 to 4 per 100 patient years. So it is as safe or as bad as most of the biologics. Another very peculiar risk this molecule has is herpes zoster. You can see around 3 to 4 of them develop herpes zoster across, and the risk stays high throughout. You take tofacitinib, risk is high. So to herpes zoster, we have seen a lot of herpes zoster, multidermatomal herpes zoster with tofacitinib. And very, very important, there is an oral surveillance study which compared tofacitinib vis-a-vis anti-TNF, very clearly showed that anti-TNF tofacitinib has higher myocardial infarction risk and higher risk of even malignancies. So approximately 10 per 100 patient years have serious adverse events. 4 to 5 will get herpes zoster, 1 or 2 will get tuberculosis, serious infection happens in 3 to 4, and probably 1 or 2 patients will develop MI or stroke or venous thrombosis. So we have to be very clear that the tofacitinib is not a very safe drug like methotrexate or hydroxychloroquine. It's a very powerful drug, but it comes with lot of side effects also. So you have to very closely monitor, titrate, and only give when indicated. Once the patient has only failed conventional DMRs or probably failed biological, then you start tofacitinib. Don't start tofacitinib upfront. That will land the patient in trouble. So this patient, she came back to me in 2006. I told that is the time tofacitinib was launched in the country, not Indian version. The important drug Pfizer launched tofacitinib at that time. In 1 month's time, I started on tofacitinib. In 1 month time, she improved. Tender joint count came down to 2, swollen joint count to 1, ESR 30, started walking. And now currently her tofacitinib was tapered to once a day or alternate day, and she is being maintained on conventional synthetic DMR. Here ESR is less. So she is achieved remission. What about cost? Cost, as you can see here, methotrexate is the cheapest, 200 rupees per month or 300 rupees per month. Combination DMRs will cost something around 1,500 to 2,000 rupees per month. Rituximab will cost again almost similar to combo DMRs. So it is it's a viable option for poor patients. Tocilizumab and anti-TNF are slightly on the expensive side, but jacnibs is again as cheap as combination DMR. The cost is 1,000 to 1,500 rupees per month, but still it's a very affordable drug. But it has to come with a baggage of a lot of side effects. You have to very clearly monitor it. DMRs are very cost effective. Again, I want to emphasize the one point, old is gold. DMRs are very cost effective and still the first choice. But the story does not end with disease modifying drugs. If the disease modifying anti-rheumatoids, conventional synthetic DMRs fail, there are other options available. So take home in rheumatoid arthritis, in DMR naive, first and foremost point, make the correct diagnosis. If you have diagnosed somebody as rheumatoid arthritis, patient is not responding in 3 months, always think whether my diagnosis is correct or do we need to revisit the diagnosis. Take the help of a rheumatologist. Extremely important because wrong diagnosis can happen from anyone because is a rheumatoid arthritis, a clinical diagnosis after all. So in rheumatoid arthritis, if somebody is DMR naive, monotherapy with step up. Start with methotrexate, add on hydroxychloroquine, sulfasalazine, whatever is the treatment of choice. In methotrexate, inadequate responders. If somebody you have started methotrexate, they are not responding. Combination DMRs are equal to anti-TNF. Either you can give methotrexate after failing methotrexate, add sulfasalazine, hydroxychloroquine, or you can go to anti-TNF, or you can go to tofacitinib also. Combo DMR failures, biological DMRs or target synthetic DMRs are good. JAK-NIPs are effective across spectrum. Be it methotrexate naive, methotrexate failures, combo DMR failures, biological failures, it's extremely effective. But the problem is, unless monitored and very carefully titrated, it can cause serious adverse events in long term. Even there is a malignancy risk. So if somebody has a malignancy or somebody has a myocardial infarction, never give tofacitinib. So rheumatoid, I just want to see from M, it has moved to T. Masterly inactivity. M is master. When patient used to come earlier days, we used to be masterly inactive. We don't know what to do in 1970s and 1980s. We will just observe them. Mind-numbing pain. People used to say, if the rheumatoid patient come to the front door, I will run through the back door because I can't suffer his pain. And misery. The patient is under severe misery. From that, we have changed to T. What is T? Time to treat. We have to treat as early as possible. If possible, within 6 months or 8 months, we have to start treatment. Treat to target. What is target? Remission. Dash 28 less than 3.2. And last, targeted therapy. Now we have anti-TNF, biologics are there, target synthetic DMRs are there, where we can hit the disease with Ramban. So M to T, from mind-dumping pain, we have come long way, and rheumatoid arthritis patient lead a normal life, for which we need to diagnose them early, control the disease well with frequent follow-ups. Thank you for listening. Happy to take some questions. Thank you.
And one, I think the one of the most updated, in very simple way. I think really you have done a marvelous job. Congratulations to
Thank
Dr.
you, sir.
Akash Singh is here and Dr. Abra. I think some questions came to me on my WhatsApp. I have posted. Can you go one by one? Do you
Yeah.
see them? Yeah.
Thank you, Shino sir, for that wonderful presentation. I'll take the questions one by one. So the first question is seronegative RA a distinct disease or just a milder form of seropositive RA?
So we always say, Abra will agree to me, seronegative, when you diagnose seronegative RA, it's like, it is most of the, you have to keep your eyes open. We have seen so many cases, seronegative, we thought it's initially seronegative. They turn out to be CPPD disease. So seronegative RA per se is usually milder when compared to seropositive. You can't say it is a distinctive disease. Rheumatoid arthritis can be seronegative or seropositive. What we should understand is rheumatoid factor and anti-CCP are the two antibodies we widely check. It is positive around 70%. If you check anti-CARP, it will become 80%. Still, 20% will be seronegative. These seronegative patients usually have a milder disease when compared to seropositive. You can't say it's a distinct disease altogether. Most of the time, it's a milder form of seropositive rheumatoid, but never underestimate seronegative rheumatoid. We have seen so many seronegative rheumatoids who have deformities.
Okay, the second question is, what is the role of musculoskeletal ultrasound or MRI in the diagnosis and remission monitoring? So diagnosis, I think you have already answered.
Yeah.
So I think remission monitoring or monitoring of the disease, we can take that.
Yeah, in remission monitoring, whether we should do MR remission, target ultrasound remission or MR remission, people have done studies of comparing ultrasound remission versus clinical remission. Clinical remission reasonably holds good. So by doing ultrasound, we pick up minor synovitis here and there, and then we keep escalating therapies, which is in long term has not been found to be beneficial. So clinical remission is good enough, but we have to do a clinical scoring at every visit.
So the third question is, when should biologic or targeted synthetic DMARDs be initiated in RA? So this question has also, I think, been answered. If the standard DMARDs.
Dr. Abra, I just wanted to add on it.
Yeah,
Actually,
welcome.
yeah. MRI is the static imaging and ultrasound is a dynamic imaging, which is well described in musculoskeletal diseases, like because of the movement of the tendons and apart from that, movement of the blood vessels. Ultrasound is very good modality for musculoskeletal if elastogram is applied. Apart because color Doppler is not available and CT MRI, so it is better choice for I will go for the ultrasound musculoskeletal high resolution power Doppler ultrasound. This is a because it's the MRI is the aesthetic ultrasound. It cannot be for moving tendons, ligaments, and other like blood vessels. Thank you. Go ahead, please.
Yeah.
So
next question is, should methotrexate be continued when initiating biologics or JAK inhibitors?
The answer is yes. You have to continue if the patient is not, if the patient has some other contraindication. For example, somebody has a chronic liver disease or cytopenias at baseline. Otherwise, we have to continue methotrexate. Methotrexate add-on therapy, it has been very clearly shown. If you add methotrexate to the tofacitinib or add something, it's always the result is better. And not only that, methotrexate is safer when compared to and cheaper also. For our country, if the patient is tolerating methotrexate and if the patient is responding to it, always continue it. And most of the time, even if patient has a DAS 28-7, you start on methotrexate. Patient's DAS 28 came down to 5. So there's a reduction of 30% disease activity, but patient has not achieved remission. Then you probably add second disease modifying drugs or add tofacitinib. Not that you stop methotrexate. Whenever we see a patient who's in our clinics who don't do well, those who are on methotrexate, not on methotrexate, where we can't give methotrexate because of MASLD or CKD. They don't do really well in long term. So methotrexate is an anchor DMR, which is extremely effective.
Excellent. So, Dr. Devanish, yes, welcome. So, I think
Thank
you
you,
can.
sir, and thank you, the Sino sir.
Thank
How are
you.
you? I think good.
I'm
Yeah,
fine, all well, long time.
yeah. Sir, I just
Yeah.
wanted
So,
to
next.
add on regarding this
Yeah, yeah.
topaz.
Go.
There was a poster in ULAR this time, and which says the single monotherapy with the tofacitinib, if taking the risk ratio benefit of it, and with the high dose like methotrexate and steroids. So it has been seen that the study showed tofacitinib is doing better in respect to even cost effective because of the fast remissions rather than going with this methotrexate and high dose steroid. And so sorry, high dose methotrexate and steroid. So this was the
So,
very
Dr.
recent.
Devanish, are you using it? What is your experience with 5 mg or 10 mg?
The which one?
Yeah,
Tofacitinib.
this is, yeah.
Yes, I am using tofacitinib since it has been launched to the biosimilar version. I have once patient I have used Geljans of this Pfizer. So to like rightly the Padmanabhan Sinoy sir has pointed out the side effect of it. I have seen all the side effects. Mostly what I have seen is a higher dose with the higher dose of the tofacitinib, like single dose of 11 milligram, that causes a lot of herpes zoster to my patients and even to some cardiovascular event also. So the keeping 5 milligram in yeah, divided dose like BD dose is safer than 11 milligram single dose. So I'm using this since pretty long time, and I have a lot of experience to have. So I have seen a whole kind of side effect what Padmanabhan sir has already depicted it.
All of us have seen,
So
all of us have
mostly,
seen, we have burnt our fingers. So that's what I was telling,
yeah,
don't start. Yeah, don't start upfront. Yeah, don't better to give
yes,
still I will, because malignancy, some malignancy can happen, especially more than
yes,
50 years. Rheumatoid arthritis, we know the risk of myocardial infarction is as almost similar to diabetes. So definitely we control of disease activity is extremely important. If methotrexate doesn't work, definitely then we can add tofacitinib. But I don't think like all of us agree that tofacitinib as an upfront therapy may not be and long-term therapy, especially rheumatoid is a long-term disease, giving it 5 year, 10 year. Probably we don't know what is there in the long term because in West they are very clear. And in the West, if you see, they don't give. They approved only for anti-TNF failures. They don't give. Most of them after anti-TNF they give tofacitinib. But in our country, we are fortunate to have tofacitinib at such an affordable price. It can really make a difference to very needy patients if given appropriately, no doubt.
So, how does Dr.
sir.
Abra, yeah, Dr. Abra, you differ or you agree, or what's your
No,
experience?
no, I agree because after Tufasnib has come, we have a lot of cheaper options and patients who cannot afford biologics. Tufasnib is like a biologic for them. So I personally start at 5 mg twice daily dose, and in many patients we can taper down to 5 mg once daily dosage.
Yes,
They
yes.
maintain well at 5 mg once daily. Once in a while, if they have pain, they can increase it to twice daily and then again come back. So we can
Right.
maintain at 5 mg once daily dosage.
Yeah, you can go to the next
And
question. Yeah.
sir, the NK Singh, sir, I just
Yeah.
wanted to add regarding the in context to the Jharkhand states.
Yeah.
So I have seen some companies they are promoting to the coax even, and I have seen a patient with even cervical spondyloarthritis. They are taking tofacitinib. They are labeling it, especially I am not naming the companies, but they are going to the coax, and for headache also tofacitinib has been given. Being considering it as a master drug and master for every kind of pain, even for the like intestinal pain they are giving. So this is a misuse. So we have to understand it because it is very wonder drug and very good drug. And for induction remission, this is also very good. In if we are considering from like maintenance remission to if we are going towards secure. So it is very good, but provided judicious use is important. In context to Jharkhand, I have just told
Yeah.
what I have seen it. Yeah, so thank you, sir.
Yeah, thank you. Yeah, Dr. Abra, next one.
Yeah, so Shenoy, I'd like to ask one question from your practical experience. Like, if you have to choose between rituximab and tofacitinib, and finances are not a concern, so what would you choose from the safety point of view?
Definitely rituximab.
That also the side effects with tufasib is, despite being cheaper,
Yeah.
is much more.
Much higher, much high. And rituximab patients, we have our own protocol. We have published extensively on this. Low dose protocols, we have our own, we have a protocol which we have clearly shown. Most of the patients don't require that this induction dose and all in rheumatoid arthritis, especially Indian patients. You can manage with a very low dose, 500 milligram single infusion, and monitor the B cell counts. So last 3-4 years back, we got a best Appler paper award for this. So low dose rituximab is enough, and it saves a lot of cost. The risk of infection is very less, and they do extremely well in long term.
Yes, I have personal experience because I was also a part of the image trial, which is also the where whenever I was in the PGI Chandigarh at the time, I was senior resident. We have started in 2005, and three centers has been identified. One is I think so the SGPJ Lucknow, and other of PGI Chandigarh. And I was as a clinical efficacy assessor for rituximab, biological naive patient to those who are not responding to usual, like methotrexate resistance. So I have seen a wonder drugs, and day 1 and day 15 dose, what we have already. This was a phase 4 control trials and post-marketing trials, and I was also part of it. So I have a personal experience, and I have started in Northeast region. I have first time in 2010 and Apollo Hospital Ranchi. I have started this rituximab. At the time, it was Mypthera and costing 1,80,000. That came down to almost 6 to 7,000 in a biosimilar version. So it is very good, provided patients should have affordability of it. But now, after coming with the biosimilarity, we have very less price now. Earlier, Mypthera was too costly, but they were affording at the time. Yes, thank you. Go ahead.
Just adding rheumatoid, it should be only given in rheumatoid factor positive. Rituximab doesn't work in rheumatoid factor negative well. So it is a very important rheumatoid factor or ACCP positive, seropositive. Yeah.
Yes. Sir, one or two patients I have given to rheumatoid factor negative, because rheumatoid factor positivity and negativity, like what we are testing for that, it's rheumatoid factor IgG M or IgG G. Mostly, most of the laboratory, they are doing this test, but they are not going for
The voice is
IgA,
breaking.
which is almost, IgA is also the very worst kind of rheumatoid arthritis with almost ulcers we can see. So the 2 or 3 patients I have given rituximab to seronegative patients, they have also responded well. They have some ulcers at that time. Yeah. Thank you, sir.
Thank you.
So, Dr. Abra, any question you are? Yeah, to 3 or 4.
There is one question, like any use of AI for precision medicine, like early identification and understanding which treatment will be appropriate.
I think it is coming up in a big way. Especially in rheumatoid arthritis. But we are yet to see a big jump. Slowly it is coming, but I think in another 4 or 5 years, their prediction models are happening, depending on which joints are involved and depending on a lot of questionnaire, it can predict. But there is a lot yet to learn. And what is going to come in future is probably based on our cytokine profile or doing the full omics. We will be able to say, now we do trial and error. Who is going to respond to methotrexate? Who is responding to tofazine? Now, I'm sure another 5 to 10 years based on the omics data, it will take 10 years, but we will be there. Based on the patient profile, AI will tell us this patient probably methotrexate is going to be not going to work. You can start probably on rituximab or tofacitinib, or patient can say the algorithm will tell us that tofacitinib is not appropriate for this drug because based on these mutations. So we will be there.
Yeah. So Dr. Rajesh Kumar Jaina from Jamshedpur, sir, how can you please briefly explain follow-up after starting DMRD, then follow-up in 3 months to see pain decreased or not? I think you explained.
Yeah.
That you explained. Dr. Noniji
My
Singh.
only thing is, my only message is, don't look only at the pain. Look at the tender joints, look at the swollen joints, look at the calculate the disease activity.
Yeah, one from the Digboi, Dr. Noni Ji Singh, a very eminent physician. How do you approach in patient having hepatitis B? So, what is the relation with the hepatitis B? I don't.
So basically, hepatitis B, once you give one of these conventional DMRs, or apart from hydroxychloroquine and sulfasalazine, all the disease modify immunosuppressants. Hydroxychloroquine and sulfasalazine are not very immunosuppressing drugs.
Hepatitis B and rheumatoid arthritis. How
Yes,
to
I'm coming to that.
approach?
So when you give tofacitinib, when you give biological, definitely they have to be put on tenofovir. And because there is a high risk of reactivation. If the hepatitis B is there, HBV DNA titer is high, or even if anti-HBC is high, definitely you have to put the patient on tenofovir. Otherwise, the chance of relapse of hepatitis B is very high. And also you have to look at whether the patient has, how bad is the liver. If the liver is really bad, better to avoid hepatotoxic drugs like methotrexate or leflunomide. So hydroxychloroquine is good, sulfasalazine is good. If they don't work, probably you can move on to biologics.
I think one more important question is there. Okay, are there any validated biomarkers to guide treatment tapering or predict flares in RA? Biomarkers asking, he's asking.
Which is
Any biomarkers?
clinically useful biomarkers are not there yet, but probably in future they may emerge. Clinically, there is nothing we can very clearly say that somebody is relapsing or not going to relapse. It's a clinical judgment with a acute inflammatory ESR and CRP. That's all. Some people have
I
And
think
sir, can it
Yes.
be
Yeah,
monitored with the musculoskeletal ultrasound?
That's what I was coming to. Musculoskeletal ultrasound,
Yeah.
if you can look at for subtle synovitis. That's what I was coming to. Subtle synovitis, you can see if the subtle synovitis is there, probably the chance of relapse is higher. That is one, it's not a biomarker, but it can be used.
I think glucocorticoid tapering in RA. So anything like on that?
Glucocorticoid, 3 messages. High dose steroids, more than 10 milligram, 20 milligram, is not indicated in rheumatoid arthritis. Low dose glucocorticoids during the initial period. There is a controversy going on whether low dose glucocorticoids are really indicated or not. I don't think in this right forum to talk this, but the general consensus is low dose steroids for a very short time is effective. 3 to 6 months is effective, but continuation of low dose steroids for a very long time is not advocated. It can have its own adverse events. So during this a bridge therapy. Till the time methotrexate or hydroxychloroquine act, you can give low-dose glucocorticoids. And low-dose glucocorticoids, in my experience, is much safer than non-steroidal anti-inflammatory. Better than giving etocoxib or these are drugs which will have disease-modifying effect in long term also. So steroids are here, but don't misuse them.
Yeah. So I think that Abra, any comment on steroids?
No, I agree with Shinay was that there's a lot of misuse of steroids, and we often see patients who are on steroids for 2 years, 3 years, landing up with osteoporosis and other metabolic complications. So early use of DMARDs is always indicated. Early and aggressive use, up titration of the dosage of DMARDs, like we usually start methotrexate at 15 and then upscale it to 20 or 25, or add on other agents if the patient is not responding. So steroids should be only a bridging therapy or used during the flare.
So that Akash, you have got any question?
Yes.
No, I don't think so. Everything is pretty well explained.
Yeah. So
Yes.
if not,
One question from the Vijay Patani, I think so. Any use of for
yeah.
precision medicine, early identification and understanding which treatment
Already,
could be
already,
Yeah, I
already
think
he has spoken
yeah,
about,
he
yeah.
has been answered, I think. So I think Dr.
Yes.
Patni, your comment, and then we will wind up.
I think
Yes.
we
Sir,
get
I
rheumatologist
just
Yeah.
wanted to add something.
Yeah.
Padmanabhan sir, are you here?
Yes,
KSM?
I am
Yeah,
here.
yeah,
I
yeah.
am here.
Yeah. The question of mine and also comments like difficult to treat RA. What are the clinical compounding factors? So I just wanted to have a comments like what are the compounding factors which is making us difficult to treat RA?
Yeah. Basically, difficult to treat RA is what Western literature says is you fail on two biologicals and one traditional or targets in the DMR and DMR. 15 drugs we have failed, and we are unable to taper steroids. So we are doing our own study. I don't think that definition is applicable in our population because having two biological failures is extremely unlikely in our population. So we have to have our own definition. So we are in our cohort, we are assessing what is difficult to treat RA. But what I can offhand I can tell you is difficult to treat RA. Most of the time there is a huge there is damage, and second, overlap with fibromyalgia. The patient doesn't feel better even after all the inflammatory markers are normal, others are normal. Truly difficult to RA after having one biological and traditional target is the DMR and conventional DMRs here is less than 5%. But the patient satisfaction less. A lot of other patients, if you see difficult to treat RA and the patient is not satisfied with your treatment, or the pain reduction is as much as not what you expect, happens around 15 to 20% in our population also. And most of the time it is associated fibromyalgia or associated damage. And this happens when the diagnosis is done very late. Once the diagnosis is done late, what happens is there's a lot of pain amplification happens, and there's a pain sensitization which goes on, and the patient starts perceiving pain even at a lower limit. So extremely important to control the disease as early as possible.
Yeah,
Yes,
Dr.
I have to add something on it, sir.
Yeah.
There is a compounding factors which makes it difficult to treat RA, like clinical the influence, like a patient is obese patient with cigarette smoking, or anti-drug antibodies like immunological factors, then to genetic factors, then some genomics causes which makes the DMARDs ineffective. And also we have a poor, like we have a limited choice of the DMARDs, and because of the side effects or poor adherence to the patients, or contributory factors like comorbidities, and sometimes misdiagnosis also, and also there is mismatch of the management goals, and like secondary damage like rheumatoid in osteoarthritis and subluxation of the joints, poor coping with the drugs, and sometimes psychological factors like some disorders, anxiety, etc. These are some of the conditions, like are also poor coping of the demands also. These are some of the compounding factors which makes the rheumatoid difficult to treat. And another questions of mine, sir, should we proceed from the remissions to cure? How should go? Either Dr. Avra or yeah, Dr.
Definitely
Padmanabhan.
remission to cure. We are now there are in lupus the people are looking at CAR T. You are looking in deep B cell depletion. What happens is rituximab do not deplete the B cells together. The depth of depletion is not that good. So we have bite therapy where we have CD3 which will bind to both the T cells and the B cells and just kill the B cells, and it's a deep depletion. So these therapies are probably going to cure rheumatoid arthritis, especially probably, we don't know. But and what we have seen in clinical practice is those who are, we identify very early, less than 3 months, 6 months. If you treat very well, probably they are near to cure, and a lot of them we are able to stop disease modifying drugs at the end of 4 or 5 years.
Great. Excellent one.
Yes. So one comment, sir, last comments. Actually, the inducing remission is prerequisite to treat RA, and subsequently keeping subsequently maintaining remissions in the good adherence in the patient with a good the treatment outcome we are expecting, and subsequently like achieving remissions with drugs, or or drug holiday or withdrawal, that suggests the possibility of the drug-free remissions, even cure in a later stage of the disease. However, there is some compounding factors or drivers which inhibits the transition from the remissions to cure. That may be then that exists not only to immunological factors, but also like mesenchymal systems, and also GIT system, nervous system, and psychological disorders. These are some of the things. So still we are eyeing for deep remission to cure, and maybe so these are the some compounding factors which I have elaborated, which is preventing us to from the remissions to cure. Sir, thank you, sir.
Thank you. Great. So, Dr. Patni, can you just give your comments and then we'll wind up.
Yeah, about 1 hour and 10 minutes of session. I'm extremely happy that the rheumatologist has probably dealt with rheumatoid arthritis very well. Not much, almost all the questions have been dealt with. So we don't have much scope of any of the further questioning or comments. So I really thank all the 3 rheumatologists for coming on this show and giving us a good kind of input on rheumatoid arthritis.
So, lastly, I
Thank
will
you.
just request Dr. Abra your take-home points.
So diagnose rheumatoid arthritis early. The diagnosis is essentially clinical with the use of antibodies, and use glucocorticoids as a bridge therapy, and start very early initiation of DMARDs. Escalate dose of DMARDs like to methotrexate, as I said, 15, then 20, then 25, or add on other agents like sulfasalazine, leflunomide. Tufosnib should not be used as a first line agent, and people before screening tufosnib, we should be screening for tuberculosis. And apart from tufosnib, other choices are there like rituximab anti-TNF. And as far as India is concerned, rituximab is the currently available cheapest, cost-effective, and safest option when people are resistant to the standard DMARDs. So these are most of the common things that most people needs to know while treating rheumatoid arthritis.
Yeah, Dr. Devanis, your last take-home message.
Yes, sir. And I was just wanted to highlight only treatment for the rheumatoid existing not only for the treatment protocols. Sometimes we are going like off-label treatment because of the shared decision between the patients and doctors also, like physician global assessment. We are assessing it and patient global assessment. Sometimes patients give lead what I should do. So it is a shared decision between physician and the patients to treat rheumatoid arthritis, and it should be with a medical protocol and sometimes with the patient choice also regarding tumors, whether they want to take biological. Sometimes they used to refuse biological because of the financial constraints. Then we have to go for tofacitinib. Sometimes aggressive and appropriate treatment also suggests tofacitinib, keeping the risk ratio benefit of it. So always patients share decisions is important to treat rheumatoid arthritis. Only we should not go only for the our own sometimes like prescribe precise to personalized medicine, then to precision medicine we are coming with. So thank you for giving this chance, and I think it's excellent presentation as usual by Dr. Padmanabhan sir.
Yeah.
And Dr. Abra Chaudhary is very good speaker also. And N.K. Singh sir is very much academics. I hardly come across CME to a lot of posting from your side, but difficult to read it
Yeah, I
in
know.
fully. And I think so Akash Singh is also there. And a very good discussion is was, and it should continue. Then I request all of you to invite the rheumatology colleagues to have this kind of incitement so we should learn. This is our responsibility from the Indian Rheumatology Association to also educate the physician, because we are very few in numbers and patients number are very large.
Yeah.
So it is a venture of the IRA also to teach a local physician so that they can treat in a better way rather than doing the unhealthy jobs for the patients. This is my
Great. So, Dr. Padmanabhan, your last take-home message for the audience.
The last take-home message is diagnose very early as possible. Make a right diagnosis, control the disease very well, achieve remission as early as possible, and patient will thank you for a very long time. Because relieving pain is like it's very relieving. Patient becomes very happy and they will thank you for their life. So, but with adequate therapy, you are able to do that. And I would like to thank N.K. Singh sir I am also part of the CME WhatsApp group. I keep learning general medicine based on from the group. It's very useful to keep you updated, and it is a thank you for the kind invitation and for a wonderful discussion. Thank you.
Great. Thank you. So, Dr. Akash, now you have to propose the vote of thanks.
I thank Dr. Padmanabhan Shenoy for excellent delivery of the topic. Basically, we have learned a lot basically from him regarding the rheumatoid arthritis and its management. I also thank the moderators, Dr. Abra Chaudhary, Dr. Dionis Jess, for moderating and for keeping up the discussion and giving their inputs during this webinar. I thank Dr. N.K. Singh, Dr. Vijay Patni for being there in every sessions, for moderating sessions, conceiving the sessions, because these sessions go a long way to help our big audience, basically, of physicians to upgrade. I thank all the physicians who have joined to hear this talk, because they are joining and their participation, their questions are the utmost motivation for all of us. I thank the USV team, the Dr. Aushik, the UC team for providing the platform to deliver this webinar. I now hand over the session to Dr. Aushik to conclude the session.
Yeah, so Dr. Arosil, you are there? I think Dr. Arosil, anyway, so she's there. So you please conclude.
Yeah. First of all, I would like to start by thanking Dr. N.K. Singh sir for bringing us another episode for CME India. I would like to thank our speaker, Dr. Shenoy sir, for being so explicit. Thank you so much, Dr. Abra Chaudhary sir, for making the session so interactive, Dr. Dionis Jess sir, and thank you so much for your presence, Dr. Vijay Patni sir and Dr. Akash Singh sir. Thank you so much.
Yeah,
See you in
thank
the next
you. Meet
episode
again.
of
So good night to you
CME.
all.
Yes.
Thank you. Great night.
Thank
Great.
you.
Good
Great.
night.
Thank you
Bye-bye.
so much,
Good
Alex.
night, all.